Hello, everyone. Ladies and gentlemen, patent ductus arteriosus remains one of the most common congenital heart conditions, and its management has evolved significantly over the past decades, particularly with the advent of percutaneous closure techniques. So today I have the pleasure to present insights from 2 decades of experience at Ibn Sina University Hospital, a leading Moroccan cardiology reference center.
Excusez-moi, juste, vous préférez le faire en anglais ou en français?
Oui, en anglais.
Ok.
I do not have any conflicts of interest to report, but I would like to thank my dear professors, Professor Nadia and Ruqayya Fillat, for their valuable contribution. So, ductus arteriosus is the communication between the proximal left PA and the descendant aorta, just distal to the subclavian artery. The PDA can be associated to a variety of congenital heart lesions. However, in adults, it is usually an isolated finding. Physiologically, ductus arteriosus is expected to close within 3 first days of life. However, it remains patent when it's beyond 3 months. So we close PDA to prevent hemodynamic complications, to avoid arrhythmias, to reduce the risk of infectious complications, although rare but exemplified by this case observed in our hospital and reported in the literature. Additionally, it prevents formation of aneurysms and other associated risks. So let's delve to our presentation. So the aims of our study is assessing the efficacy and safety of PDA percutaneous closure, assessing the role of imaging modalities such as echocardiography and angiography, and investigating the feasibility and of short-term and long-term outcomes and complications. So we conducted a retrospective, observational and descriptive single-center study of PDA closure in Ibn Sina University Hospital, and we gathered 87 patients with isolated PDA. These were our inclusion and exclusion criteria. The average age of our sample was 17 years and 1 month, with a median of 13 years, and the youngest patient included was 4 months old. The oldest was 74 years old, with the standard deviation of 16.9 reflects a wide age distribution. There were 58 females, 29 males, yielding a female-to-male sex ratio of 2. For personal history, consanguineous marriages was seen in 7 patients. Trisomy 21 was seen in 3 patients. Smoking was seen in 1 patient, although its direct association with PDA is not well documented. Rheumatic fever and hypothyroidism were seen in 1 patient. Clinical presentations were dominated by respiratory symptoms in dyspnea in the first place, followed by continuous cardiac murmur, and then other rarest signs such as heart failure, headache, and syncope was seen in 2.3% of patients. So, based on clinical and paraclinical investigations, 3 subgroups of patients were identified. The majority of 64% of patients had increased pulmonary flow without pH, forming the majority of patients. 18.4% presented non-fixed pH, and 17.2% had no sign of pH. So following the Krichenko classification, here's an histogram illustrating the distribution of cases with a predomination of type A. Unplastered duct occluder 1 was exclusively preferred for large and colical PDAs with 49 cases. For small and tubular PDAs, ADO2 with the lead of 25 cases, and followed by coils, LifeTech occluder, and then MVSD, which is a muscular ventricular septal defect occluder. which was reported in this case of an 80-year-old girl patient who presented in our department with the class 3 dyspnea. TTE revealed PDA. In angiography, we had Krichenko type F. And then a 10 millimeter MVSD plaster occluder was then advanced. And it was closed successfully.
Please, we will have to go to the conclusion.
Okay. We had favorable outcomes with no death or major adverse effects. And so, as we said earlier in the presentation, there is the advance of non-radiation and contrast techniques. So we finish with the conclusion. This work does not only highlight significant progress in the management of PDA within our country, but also it offers valuable insights that can contribute in global prescriptives on congenital heart disease interventions. And we are looking ahead to the opening of our new university hospital in 2026. Thank you.